I'm thankful to Dr. Chauhan and team to give me yet another chance to moderate the session. So it's my duty to introduce Dr. Sunil Kumar Gupta. He is Principal Director and Head of Department, Hemato-Medical Oncology and Bone Marrow Transplant at Moderator Hospital. So Dr. Tulsi is especially guided not to speak too much. He has been attached with Fortis Hospital, Shalimar Bagh and Noida. He has been Consultant and Chief Head and Neck Services at Rajiv Gandhi Cancer Hospital. He has been also attached with Shanti Mukund Hospital, and he has been Consultant and Coordinator Hemato-Medical Oncology at Dharamshila Hospital. So all the big hospitals in NCR, he has given his services. He has more than 33 years of experience in oncology. So let us learn from him what is new. Thank you, sir.
ये रहने इधर के रहने
Yes. Very good evening, dear friends, ladies and gentlemen. At the outset, really thank the physician forum of South Delhi and especially Dr. Sushil Chauhan and his team. Today I would like to discuss about how physicians' roles are important in clinical practice. As Dr. Kalra mentioned very clearly, for last more than 3 decades I am practicing as an oncologist in Delhi, and I basically established so many cancer centers in Delhi. When I started my cancer practice in Delhi, first cancer center was Dharamshila Cancer Hospital, and now you can see in last 3 decades there are more than 40 comprehensive cancer centers in Delhi. So there is a revolution, and cancer means a multidisciplinary approach. And once we are talking about multidisciplinary approach, means surgical, radiation, medical, supported by the radio diagnosis department and others. But what is the new things which I am discussing in front of you? I would like to discuss, there is an exceptional response to third generation TKI, even despite of a metastatic disease of non-small cell lung cancer in clinical practice. If you say last 2 decades, there is a lot of change in clinical practice of medical oncology. When I started my practice in Adyar Institute in 90s, people are talking about a pills form treatment in the form of endoxon, methotrexate, simple oral drugs and few injectable cytotoxic drug. Now it's an era of the targeted therapies and the checkpoint inhibitors, ADC, and even the new drugs daily. So why I am discussing about the exceptional role? Because once we are discussing about any cancer treatment, we always have a thought in our mind that through the hematogenous route or the lymphatics. This disease is spread to the various organs, and one of the most vital organ is brain. And once there is a disease in the brain, we always thought it's end of roads and only palliative treatment in the form of palliative cranial radiotherapy. Is it so? So I'm discussing about the new era of medical oncology and role of new drugs, because once we are talking about the new drugs, they crosses the blood-brain barrier. So I'm discussing a very special case in front of you. October 2020, Mr. X, a 64-year-old gentleman, presented to us with complaint of cough, progressive breathlessness, and severe backache. He could not walk without support in the last 10 days because of the severe backache and giddiness he felt for 5 to 6 days. And in one month period, he lost roughly 5 kg weight. And he's a non-smoker. And once any guy is non-smoker, they always not thought of a cancer as a diagnosis in clinical practice. So once he underwent the PET CT scan in October 2020, a mass lesion seen in the right upper lobe and multiple bone mats. You can see the PET scan. You can see that there is a classical sun rays appearance of SUV, classical feature of lung cancer with multiple bone mats. So in October 2020, we did a lung biopsy from the primary site, and as per the histopathology, patient had a histopathology of adenocarcinoma, and we always go for a ISC, and ISC is basically TTF positive, napsin positive, and negative for P40 in favor of adenocarcinoma. And it's an era of molecular diagnostic test. And recently we are talking about NGS, next generation sequencing, and basically the driver mutation EGFR19 was positive and rest of the driver mutations were negative by the NGS. This is not changing.
सर उससे डायरेक्ट कर लीजिए
डायरेक्ट कर लो
एरो डाउन सर एरो डाउन
Yes. And in November 2020, in consideration of a giddiness, the MRI was done. And this is suggestive of a multiple ring enhancing lesion in the cerebellum and cerebral hemisphere with classical vasogenic edema. You can see that there was a classical vasogenic edema, and that's why there is an increased intracranial pressure and patient has a giddiness and unable to walk. You can see by the MRI very clear picture. So final diagnosis. Clinically, metastatic non-small cell lung cancer, stage 4, bone and brain mets, histopathology adenocarcinoma, driver mutation, EGFR, deletion 19 positive, rest of the driver mutations were negative. So once patient is having a classical severe backache, unable to walk, our moral duty to give symptomatic relief for the back pains and weight-bearing sites. And we always go for a palliative radiotherapy in such cases with bone-directed chemotherapy, hyaluronic acid as a standard care. In consideration of EGFR mutations positive, we have a targeted therapy now. And we are having a targeted therapy known as a TKI, as a tyrosine kinase inhibitor, which hit the specific EGFR mutation deletion 19 as an option, like Osinertinib as a third generation TKI. Why I am discussing about this? In last 2 decades, there is a lot of development in the field of oncology in the form of drugs. In 2000 and 2010, we are discussing about first generation TKIs for specifically for lung cancer patient, and they specified, say, those who are having adenocarcinoma, female, Asian origin, non-smoker, bronchoalveolar carcinoma, classical targeted therapy is TKI first generation Osimertinib. Okay? Just in the overall survival of Osimertinib, 9.5 months in a metastatic disease. In 2000 to 2010, we are talking about this. Slowly we developed the second generation TKI, Afatinib and Dacotinib. The survival slightly increased, but toxicity was more. But today I am discussing about the new era of TKI, third generation TKI, Osimertinib, and just see the survival is more than double from 9.5 to 18.9. And what is the changes between the first generation, second generation and third generation TKI? If you see first generation and second generation TKIs, they never cross the blood-brain barrier. But the third generation TKI, you can see that brain Cmax is very, very high with the Osimertinib, 2.78, while the first generation is less than that, and even the second generation is basically low level of quantifications of blood-brain barrier. Even the plasma-brain ratio is again very high with 3.4 as compared to the first and second generation TKI, and this is the major difference in the treatment options of third generation TKI versus the first and second generation TKI. Now I am showing the classical picture. We are always talking about the brain MRI, I'm discussing about the diffusion of brain once the drug crosses the blood-brain barrier. How there is a difference once blood-brain barrier is crossed by the TKI. These are the 8 subjects, but I am showing a very, very different picture in front of you. If patient is on a baseline, basically day 1 PET scan and diffusion study shows, and after the 6 hours later of Osimertinib, there is a purple color changes in this. You can see the drug is crossing the blood-brain barrier and showing the effect in the parenchyma of the brain. And day 21, there is a classical purple shadow seen in the brain parenchyma. This means this drug is effective even in a brain match once there is a blood-brain barrier crossed by this drug, and this is by the standard mouse classical testing. And you can see the second patient again, the purple color is showing that this drug is basically involved in the brain as well as in parenchyma to show the effect. So now I am dissecting this case into 2 parts. Suppose a patient who is newly diagnosed with the EGFR mutation patient as an upfront, and patient is having a brain mass. If there is no symptom, means patient is asymptomatic, and roughly 5 to 10% patients are asymptomatic, doesn't require any treatment except the third generation TKI Osimertinib as an option. But suppose patient is symptomatic. The question is how many mets in the brain? If oligomets, my choice is a neurosurgery to surgically remove the oligomets, or if the size is more, my radiation oncologist always say, please discuss this case in tumor board with the neurosurgeon. If oligomets, we should go for a surgical removal, or as per radiation oncologist, up to 3 to 5 pets, they will go for a SBRT. Is the standard care instead of going for a palliative whole brain radiotherapy, which is only required in a specific multiple mets or when patient is not fit for SBRT. But suppose patient is having a progression of disease, initially treated, and there is a progression of disease, receive the first generation and second generation TKI, which never crosses the blood-brain barrier. You can go for a third generation TKI, or you can go for a mutation of first and second generation failure by the T790 mutations. And once you feel that there is a T790 mutation, immediately switch this patient on a third generation TKI Osimertinib. If patient require a local therapy in the form of surgical removal by the neurosurgeon or by radiation oncologist, as a case of SBRT, the option for local treatment is always available as a multidisciplinary approach. This is the trial, this is the basic of landmark study showing that this drug once crossing the blood-brain barrier, even effective in brain mets as well as effective in non-brain mets patients. You can see a classical survival advantage 15.2 with the third generation TKI, with the first generation TKI 9.6, and classical hazard ratio 0.47. If any hazard ratio is less than 0.5, is very, very significant in clinical practice. Even without brain mets, the survival is more 19.2 versus the 10 months with the standard first line, first generation and third generation TKI. The Kaplan-Meier graph clearly shows a widened things, and this drug is a treatment of choice in 2026 and one of the best option available for even a metastatic brain patient, MATS patients. You can see even survival 15.2 as per the Flora trial. They analyzed and dissect brain mets and they found that this drug is effective as compared to the first generation TKI and double response rate. So in November 2020, the patient bone mets, he received the palliative radiotherapy and bone directed chemotherapy, zoledronic acid, for pain relief because he want to get the things immediately improved and symptomatic relief. But he denied for the brain radiotherapy. He said, I will not receive brain radiotherapy. I have already received the radiotherapy to the bones, and in consideration of that, we started the latest treatment as per the American guidelines, Osinertinib, 80 milligram daily for this patient. You can see in March, 4 months later, the patient changes in the sense of a scan. The tumor mass is almost 50% reduced, and reduction in the right hilar as well as paratracheal lymph node. The scan shows an excellent response and clinical improvement of symptomatology of the patient. So this is the effectiveness of a TKI. For a medical oncologist, this is important. For physician point of view, I'd say that the EFSA as well as EFR is in favor of third generation TKI as compared to first and second generation TKI. In February 2021, almost a year later, more than a year, the MRI was normal. Because this drug crosses the blood-brain barrier, the MRI was showing a vasogenic edema, the mass totally disappeared. Even in July 2021, complete resolution of brain mets, no additional intervention was needed, and patient was symptomatically better and he behaved like a normal person. The scan was totally normal. This is the real world case. This is a real world case reported by the international journal. A 53-year-old patient relapsed while being on a chemotherapy for stage 3A. I am discussing a case in a metastatic disease. They are discussing a real world case that stage 3 is a locally advanced disease. You can go for a surgery up front in such patient. Subsequent scan shows a progression of disease, and patient was on Osinertinib 80 milligram and planned for a surgery, but basically not done surgery. You can see there was a involvement of the brainstem, edema, and again responded very well with the TKI. Another real world case reported on a Osinertinib with brain mets, again published in an international journal. Complete remission reported by this drug. I am not saying that radiotherapy is not the standard of care. I say in few patients, those who are not willing for the radiotherapy, or you feel that the patient is having a asymptomatic brain mets, you can switch on the Osinertinib and wait for radiotherapy once patient is symptomatic. Another case reported by the Neuro-Oncology journal, they always says that patient responded very well in a small brain mets, or those who are crossing the blood-brain barrier by this drug, patient is having no need for radiotherapy. I always say radiotherapy is a backbone once there is a brain mets. Neurosurgery is a backbone if there is a oligomets, because we want to talk about a curative intent treatment despite of brain mets in a present era of 2026 by the American guidelines. You can see in November 2021, the CHET scan was normal. Even there was no disease reported in April 2022. So key points which I want to discuss. My friend Manoj is here. He always believed that there is a role of radiotherapy. I am not denying about that. I always believe in SBRT if there is a brain mets. But suppose the patient is not willing, what you will do? The third generation TKI crosses the blood-brain barrier. I have mentioned about the Cmax as well as brain and plasma ratio. Radiotherapy is one of the backbone in majority of time when required for palliation as well as for cure. Even for CTRT, if there is a locally advanced disease stage 3B, my choice is CTRT as a curative intent treatment. Almost complete response seen. I have shown you my case, I have shown you the world case, neurological case, that this drug shows a magic, and this magic is in last 1 decade we have seen. No adverse effect reported. The important thing is that patient was progression free for more than 19 months. He is asymptomatic. My words are very specific regarding this patient. Patient is asymptomatic, fully active, goes for morning walk and yoga session, leading a normal life by this new era of third generation TKI. So excellent response to third generation TKI osimertinib. Are such tumor different, or some tumor biology is different in which these patients responded so well and patient is in CR? Do we have any biomarker to predict such excellent response? Future will tell us about the NGS report. Thank you very much to listening me patiently. If you have any question, you can ask. Okay, thank you.
Can we have some lights on, please?
Naresh, there are light jala do.
So that I can read Dr. Manoj Sharma's biodata. That's nice. Okay, friends, so after that mastery talk by Dr. Sunil Gupta, we have Dr. Manoj Kumar Sharma, who is the Director and Unit Head of Radiation Oncology at Venkateshwar Hospital, and he is going to talk about modern radiotherapy in cancer treatment. Go ahead, Dr. Manoj.
Hello. So, good evening everyone. Thank you Chairperson for the brief introduction, and thanks for the Physician Forum of India, South Delhi, for giving me this opportunity. So my topic is the recent advances in the radiation therapy. As we know, around 90% of the patients, cancer patients, require radiation therapy either in the form of radical, neoadjuvant, adjuvant or palliative. So what is radiation therapy? It's a branch of science, medical science, which treat tumor by X-rays or photons. So this is the normal workflow in a radiation department. So whenever patients come to our department, the first step is the immobilization. So what is immobilization? Immobilization, patient comes, we keep in a certain positions so that certain positions so that it not deviate during the radiation therapy. So the next step is the CT scan or MRI scan. And after that there is the image fusion, and after that image fusion we delineate the target where to give radiation and where not to give. That means to delineate the normal structures. After that there is the treatment planning, plan verification, pre-treatment imaging, and this is the treatment. This whole process usually takes 2 to 3 days before starting the radiation therapy. In the past, in the 20 to 30 years back, we have only two-dimensional radiotherapy in the form of either the cobalt 60 or simple linear accelerators. But with the advent of CT scan imaging, better imaging techniques, there is a reform in the radiation therapy also in the form of conformal radiotherapy, and these are basically of 2 or 3 types. One is the 3D CRT, that is the 3-dimensional conformal radiotherapy, and another is the IMRT, is the intensity modulated radiotherapy. Now what is the difference with that? In the 3D CRT, we only conform the radiation to the tumor, and we can save the normal structures. But in the intensity modulated radiotherapy, we can modulate the intensity of radiation within the tumor, so that if we want to give more radiation within the tumor higher, in certain points we can give that. So this is the basically difference between the 3D CRT and the intensity modulated radiotherapy. The purpose of these two techniques is basically to improve the target dose uniformity, selectively avoid critical structures and normal tissues, to deliver higher than conventional doses, and focal dose escalation to specific subvolumes in the target volume, that is the SIT, and better sparing of critical structure, especially during re-radiations. So next technique is the IGRT, that is the image guided radiotherapy. This is the one step ahead of the IMRT. In this, what happens whenever the patient goes for the radiation therapy, we take a scan, and that scan is matched to the prior scan we have taken for the imaging. So if any discrepancy occurs during the treatment, we correct on board so that the accuracy of radiation delivery up to the sub-millimeter level. So what is the advantage? It's a more precise, real-time monitoring of tumor position and size, more targeted radiation shift to the tumor, and of course higher dose radiation delivery, potentially increasing treatment effectiveness. During the 2D or 2D dimensional acrobat, we were not able to increase the dose of radiation to the tumor because of the toxicity to the normal structures. But with the advent of IGRT, we can save the normal structure very well, so that we can enhance the tumor dose. So less radiation to the healthy organs and tissues, reducing the side effects and the complications. Now another technique is a rapid arc. Now what is the rapid arc? As we know, certain organs, tumors like prostate, lung tumors and the liver tumors moves with the respirations. So in this technique, the whole treatments complete within the 2 minutes, so that the movement part of the tumor we overcome with this. So this is called the rapid arc. These are the different machines which allow us to for these treatments like IMRT and the IGRT rapid arc, and these are the Clinic IX, TrueBeams, tomotherapy and the CyberKnife. In our institute, we have state-of-the-art Versa HD machines. Now what is the tomotherapy? Tomotherapy is a technique of the radiation therapy in which we treat tumor slice by slice, so that a large tumor, like if we want to treat the cranial-spinal irradiation, we can treat in the single fraction without giving any gap. So tomotherapy comes in that. Now we can see that this is the evolution of the radiation oncology from the 2D planning to 3D and of the IMRT, and with this picture we can see that how we can chisel out the clarity of tumor and the normal structures. Now what is the FDG or body pattern? As we know that now PET-CT has increasing role in the field of oncology, whether in the diagnosis or in the treatment planning. So nowadays we are doing PET-based treatment planning. So what are the advantage of that is better target delineation and the more precise treatment. This is the case of head and neck tumor, and we can see that we can clearly delineate the tumor that is in the yellow colorations, and we can save the normal structures like oral cavity, spinal cord, and the bones. The neck node also, and after giving the radiation, there is a complete remission of the tumor. So this is the beauty of the PET-based planning, in which we accurately delineate the tumor and the normal structures. Now, what is the stereotactic radiotherapy? Now, if we want to give the whole radiation in a single fraction, that is called the stereotactic radiotherapy, and it is a highly precise, non-invasive and alternative to surgery. Now, where we usually give this stereotactic or SRS treatment is either in the brain mets, recurrent brain tumors, meningiomas, AVM, pituitary adenomas. These are the areas where we give SRS. These are the different ways, whether it's the X-rays or the gamma, from which we can give the radiation therapy. Stereotactic radiotherapy is given by either X knife or a gamma knife. Now, if that treatment is divided into 2 to 5 fractions or 3 fractions, that we call the fractionated stereotactic radiotherapy. Now, where it is used? These type of treatments we use where the tumor is residing near to the critical structures like brainstem, optic chiasma or optic nerve. SBRT. As we know, in a typical cases like head and neck cancer, usually the dose given is 70 gray in 35 fractions, 5 days a week for 7 weeks. That means 7 weeks of treatment. But with the advent of newer imaging and radiation techniques, we can give the whole treatment into 3 to 5 fractions. That means within a week the whole treatment can be given. So where we can give all this treatment, that is mostly in the liver tumors, lung tumors, pancreatic tumors and the prostatic tumors. That is called the stereotactic body radiotherapy. Now, motion management, it is a very important for the precision radiotherapy. Several methods are available, but in our center we use ABC, that is active breathing coordinator, and with this help we can see that with this ABC we can see that we can save clearly the heart and lung very well. So this kind of treatment is required in the breast cancer, especially in the left side. This is another example of HCC, and we can see that we can delineate the tumor, and after pre-radiation, this is a big tumor. After 6 months of post-radiation, there is a complete remission of the tumor. Now, what is the proton therapy? The proton therapy, basically in India we have 2 centers. One is in Apollo Chennai and the second is in Mumbai, TMH. So what is special about the proton therapy? It is a type of a radiation therapy which have very peculiar radiobiological properties, and in this there is no exact dose. When there is not an exact dose, that is fall of dose is very less, so that we can save the normal structure very well. So these kind of tumors we can treat with the proton therapy. Now we can see what is the difference between this proton therapy and the normal photon therapy. This is a normal case of a posterior fossa tumor, basically a medulloblastoma in a children, and we can see we can save all the interior structures very well with the proton therapy, and this is not possible with the normal photon therapy. This is another example. You can see how we can save the anterior abdominal organs very well as compared to the photon therapy. And same with this lung tumors, photon versus proton, and this you can see we can completely save the right lung. The tumor is in the left lung.
Can we have some silence at the back, please? Thank you.
Another example that is in the brain tumors. In photon therapy, you can see there is a dose to the normal brain also, but in the proton therapy, we are seeing that there is absolutely no dose of radiation to the normal brain. This is the beauty of the proton therapy. Now, this is my first international paper in the proton therapy when I was doing the fellowship in the New York, and I did a small study in CS cervix. So it showed that how we can save the normal structures with the proton therapy of bladder or a rectum. Now, what is the brachytherapy? Brachytherapy, usually now, first of all, we have learned about what is the external beam radiotherapy by the linear, and the brachytherapy is the technique where the radiation source be kept close to the tumor. That is called the brachytherapy. And these are the different types of intracavitary, interstitial, intraluminal, or surface mode. The same what we did in the external beam radiotherapy, we have done with the brachytherapy, that is the image guided brachytherapy. This is always either CT based or MRI based brachytherapy, and the main concern is again the same, to save the normal structure and enhance the dose to the tumor. This is the typical case of cervical CS cervix, in which we can see that with CT based planning we can save the bladder and the rectum very well. This is a case of basal cell CA treated with This is the case of a basal cell carcinoma of eyelid, and we have treated with what we call the hybrid plan. Hybrid plan means it's a combination of electrons and the photons. And after giving the 60 grain 30 fractions, this is the result. And I can say that no other treatment modality, whether surgery or chemotherapy, can produce such a wonderful result, but a radiation therapy can produce. Hello. Hello.
Dr. Manoj, try to finish, please. You have some question answers. Yes.
Hello. So I was saying that this is a case of basal cell carcinoma of eyelid, and we have treated this patient hybrid plan with electrons and photons, and after giving the 60 grain 30 fractions, and we see the result. Then I can say that no other modality, whether surgery or chemotherapy, can produce such a wonderful result, but we can do with the radiation therapy. So our journey is from COBAR 62 3D CRT, IMRT, IGRT, and the higher technologies. Thank you. Any questions?
Dr. Sunil Gupta.
Dr. Sunil, please.
लाइट जला दे भाई.
So we had two wonderful sessions, and Dr. Jaspreet sir, खाना खा भी नहीं, खाना खा, please have your dinner. So we had two wonderful sessions, and despite the fact that it was a very solemn day today for us, as I had announced, we still had a very good gathering. When you have 52 people, 52 doctors attending, I think, ma'am, खा जाते तो अच्छा था, कोई बात नहीं, no problem. I leave it to you. So we would have the context from our moderators. I have two cases today to discuss with my wonderful speakers. Dr. Kalra first, to set the tone and the context for the first meeting by Dr. Sunil Gupta.
Sir, very, very nice talk. We learned many things. But when I was reading about TKIs, and we came to know about TKIs when we were treating immunological disorders, autoimmune disorders, JAK inhibitors. So they were very famous. And then also in COVID era, JAK inhibitors were used for some autoimmune type of inflammatory state. So this was wonderful to know that the third generation Osimertinib is one of the best medicine available for metastatic lesions in the brain. And it was just like we have now electronic digital locks. You can open from a distance, like you have mobile controllable from your mobile. So that way, this is the medicine which can control or inhibit or destroy the metastatic lesions in the brain. Wonderful to know about that. Are there any reservations where you can't use them?
There is no reservation for a TK except there is a hypersensitivity reported for a patient those who are having a skin disease, corrective tissue disorder. Sometimes these patients are having a cutaneous rashes because of the side effect of the TKI. If they worsen, try to avoid that. Or patient is intolerant to the particular TKI. Means routinely the Tagrisso is a drug which is very much tolerable, but sometimes there is a irreversible changes, slightly increase in the creatinine values, sometimes skin rashes, you can have a diarrhea, sometimes neutropenia, but this is manageable by the medical oncologist. There is no need to dose modification. 80 milligrams is the standard dose throughout the globe. Third generation TKI, if there is a EGFR mutation, deletion 19 is positive or 21 is positive, the third generation TKI Osinertinib is the treatment of choice for all the patients. Number one. Now this is the new era that those who are having a EGFR mutation 19 positive and basically adenocarcinoma, the FLORA-2 trial shows that you can combine with the cytotoxic drug, means pemetrexed and carboplatin, minimum 4 cycles of combination with Tagrisso, followed by maintenance of pemetrexed, which is giving almost a double survival even in a stage 4 patients by this combination. So this is the new concept in 2026, that combination of this trial of cytotoxic drug with Osinertinib is the standard care instead of single TKI as an option.
So, Dr. Sunil, just to extend his question, so do all the third generation TKIs cross blood-brain barrier? I believe just 2.
Means if you see, presently we have a third generation TKI only Osinertinib, not the other one. And basically the Chinese drugs are available. But Osinertinib results practically, basically if you see, I have mentioned about few things, Lux 3, Lux 6, Lux 9, basically for first generation and second generation, they excluded the brain mets. And because the Cmax was not reported with the first generation and second generation TKI, so they avoid and dissected these brain mets. But for Osinertinib, once they crosses the blood-brain barrier, Cmax and plasma values are high, and that's why they analyze the role of this drug in a brain match. And this is as per the American guideline. Osinertinib is one of the drugs which you can advise. But other drug like Osinertinib as well as Osimertinib is for exon 20 is advisable. But this drug is advised for 19 and 21.
So friends, Osinertinib probably crosses the blood-brain barrier. Also, I believe Osinertinib crosses the blood-brain barrier. Now, let me talk about the toxicity of 4 or 5 third-generation TKIs.
If you see, Osinertinib is one of the very tolerable drugs. Osinertinib combined with the Osimertinib is not a very good drug. This is a little bit, you can say, is having a more side effect in patients, like in a form of neutropenia, diarrhea, skin rash. Even the infusional reactions are reported with the Osimertinib. And number of times the first cycle is very dangerous. Always take precautions once you are going for infusional therapy of Osimertinib in exon 20, because sometimes patient is having anaphylactic shocks.
So very well understood regarding the EGFR mutant lung cancer. Talk us about there's a new hope for lung cancer patients with HER mutation.
If you see, the science is moving very fast. The NGS results basically giving us so many ideas regarding the new generation. These few Chinese molecules are available, which is not basically approved by the American guidelines, known as the NCCN guidelines. They mention about that. They always believe that the Americans prefer Americans' innovative research product as a first line, but Chinese has shown in phase 3 trial, like other trials, that these drugs are effective, like Osinertinib, even better than Osinertinib. They have shown the results, but in clinical practice till date we have not used. By experience with the new drugs, which is not approved by the DCGI of India, as well as FDA, is not available in India, and we have not used in clinical practice.
Very well, sir. This is not available in India, but US FDA has approved this new drug just in February 2026.
Actually, so many drugs are approved by the US FDA. But if the drugs are not available in India, or as per the DCGI, you cannot advise to any patient in India, because to import this drug, you need an import license and you need a verification of that. Until unless you have a substitute of this drug is not available, you cannot advise. Yes, these drugs are available, but Osinertinib is approved by the FDA as well as per our DCGI, and as per the guidelines, standard care is a category 1 recommendation. You cannot replace until unless proved otherwise by the Indian guidelines.
So you showed wonderful cases. Let me talk to you about one great case, a 74-year-old woman, a lady from London. Susan was her name.
Yes.
You remember that case? Okay, let me, also for you. So this patient had HR2 positive CA breast, CA cervix, thyroid cancer, and developed early onset lung cancer because of incessant cough for about 4 to 6 weeks. So she was HER2 positive, and she was she had undergone surgery, radiotherapy, chemotherapy, and the lung cancer came back. See, the early stage lung cancer, even after surgery and chemo and radiation, came back. Then she was put on this new drug, which US FDA has approved, the Osinertinib, which is a HER2 inhibitor. It's 3 years now that her lung cancer has not relapsed.
If you see, HER2 receptor is a 3 decades history. I was involved as a principal investigator when I was in a Dhanashira Cancer Hospital. I was involved in a BCR 006 trial, and we used this drug at time as a HER2 receptor blocker. But today it's an era, we have a number of drugs to block the HER2 receptors. And every solid tumor, we always check by the NGS, means next generation sequencing with PD-L1, HER2 receptor also, whether the GI malignancy or the colon malignancy or esophagus or a gastric malignancy, despite of breast cancer. Now we are talking about a dual inhibition in HER2 receptors by in the form of leptinib combined with the capecitabine. We have a new drugs, pertuzumab combined with the herceptin. We have a new drug like ADC like Osimertinib, and today I will confirm you that the new era of combination of pertuzumab with Osimertinib is a new concept. And this is the new concept, and tomorrow I have an CME on the same concept that this is breast 009 is the result shows that this combination is more effective rather than ADC means Osimertinib as an option.
So let me conclude. My last question to you would be regarding ablative radiotherapy. So talk of this is not only about control of metastasis, it's also ablative. So talk us about the ablative radiotherapy in oligos metastasis disease.
Ablative means complete remission of the disease with the help of radiation. So these kind of radiation basically is the SRS, SRT, whatever and the SBRT, whatever discussed. So in a brain tumors, the metastatic brain tumors, either single, we can go for ablative radiotherapy in the form of SRS. Now, with the advent of newer techniques, we can treat the number of brain metastases in the ablative form without giving the whole brain radiation therapy. Whether it is, we have treated the brain metastases up to 5, 6, 7 in a single fraction or in the fractionated. The same way, the sir was talking about the recurrence in the lung cancer after giving the radiation. So the SBRT is the answer to that. So with the SBRT, we can give the higher dose to a particular point and saving the normal structures so that the complications are less. And it's seen that even in the metastatic setup, if we give the radiation to the primary of the lung, there is that effects also with for the metastatic. So these are the beauty of the radiotherapy in the form of the SBRT.
Thank you. So it's not only the brain, it's also the lung, it's also the bones, it's also the liver. See, when OMD is there, you need to give this radiotherapy. Thank you, sir.
I have a few cases to discuss with Dr. Sunil and Dr. Sharma. Rahul, can you please put the first case here? Swelling here, the neck. Sunil, I have the first case here. Dr. Sharma, you can also because I'll be requiring Dr. Tulsi.
The light of light of
Dr. Sharma, please come here.
light of क्या कर रहा है ये?
So this is a patient who is 60-year-old. Light बंद कर देगा. He came with a swelling in the left submandibular region, and he basically is a tobacco chewer for last about 26 years, and he came to me with this swelling. So I referred him to one of my ENT friends, and he said that we need to do a biopsy for this patient. So they did a biopsy for this patient, and the diagnosis was squamous cell carcinoma. So after we did the biopsy and we did PET scan for him, there was no metastasis, the only active lesion was this. Patient was referred to an oncologist, one of our close friends here in South Delhi, Dr. Amish Mura, and he gave 8 cycles of chemo to this patient, and the patient had complete remission of this. When he came back to us in February, this was somewhere in December, when he came back to us in February, there was no recurrence on PET scan, everything was fine. But the patient started having some pain here and some bleeding from here. And that is when we got him evaluated again, got a PET scan done. In March, the PET scan was okay. But we thought probably that there is something else that we are missing. So, वो photograph दिखाओ जो bronchoscopy वाला जो picture है वो ठीक है. ये वाले. So, this patient नहीं, ये कृष्ण कुमार यादव है, ये वाला patient है, ये तो second patient है. National Institute of Tuberculosis and Respiratory Diseases, Mr. Ganesh Prasad. Anyway, leave it. So I referred this case because there was an issue of the budget. वो वाला दिखाइए, report दिखाइए please. So we referred this to National Institute of Tuberculosis. National Institute of Tuberculosis and Respiratory Diseases. His endoscopy was done there, and this is the report. ऊपर कीजिए please. So multiple fragment segregate measurement microscopy. और ऊपर कीजिए please. और ऊपर कीजिए. Keratinizing squamous cell carcinoma. The first biopsy which was done in PSRI was squamous cell carcinoma. Chemo given. Radiation given in Batra. Patient had complete remission, nothing on PET scan, and this was totally normal. Since there was nothing on PET scan at that time, we did not investigate it. We thought this is the primary and there is no secondary. Nothing. But he came back with symptoms. When he came back with symptoms, we investigated him again. And this is the time when we looked, he had a mass in the left bronchus, and the biopsy from the keratinizing squamous cell carcinoma, and he had continuous bleed from here orally, perorally. I referred him to Dr. Amish Mora again. Dr. Amish Mora said that we should either consider giving him immunotherapy, or we should consider giving him another course of chemotherapy. So the immunotherapy which was imported was about 12 lakhs, but there is one Chinese molecule which has come, and that is about 2 lakhs of immunotherapy. So PDL1 was done, and PDL1 was positive. The figure was 60%, which was supposed to be good. Now I want to know from both of you gentlemen, first from you, Dr. Sunil, how would you approach this patient from here on?
Actually, if you see patient as per your statement, PET was normal and there was a localized disease at some mandibular region. Okay, some mandibular region, or you can say at the mandibular region. But histopathology was squamous cell carcinoma. So, number of times there is a head and neck cancer, which is having a field cancer in due course of a time, known as the aerodigestic tract involvement. Probably this is one of the reasons of aerodigestic tract. Nothing more than that. It's a squamous cell carcinoma. The immunotherapies are routinely less than 2% chance positive in squamous cell carcinoma. But in a head and neck cancer, you have more chances of PDL1 positive. Pembrolizumab is the treatment of choice with 5-FU cisplatin if there is a disease for head and neck cancer. If there is a squamous cell carcinoma, you can go for a pembrolizumab, paclitaxel, carboplatin as an option. You can go for a squamous cell carcinoma, gemcite, cisplatin as a second option. For a lung and covering the head and neck. So majority of time, when there is a squamous cell carcinoma, you cannot differentiate between the primary, as per pathologist, whether this is from the head and neck or from the lung,
So
until there is a history.
In this case, could we make out whether this was the primary or this was the secondary?
Probably,
We cannot.
probably, if more than 2 years, then second malignancies are seen. But less than 2 year period, there is always a metastatic disease. 20% patients and okay. Once you diagnose that probably this is a lung, I personally feel that once disease in the submandibular region, you talked about a chemotherapy. No role of radiotherapy because already received as a local treatment previously. Always go for a systemic treatment. Targeted therapy in checkpoint inhibitors. PD-L1 is more than 60%. Pembrolizumab is one of the best drug available. Shows a response with paclitaxel, carboplatin. Standard care throughout the globe. Prognosis totally depend upon 3-cycle response with the checkpoint inhibitors. If there is a response, you can continue the pembrolizumab for 35 cycles total in lung cancer patient. If there is a response with the checkpoint inhibitors, 35 cycle is maximum you can give as a patient those who are responding in a lung cancer patient.
Cost of therapy.
Cost of therapy is not very important nowadays. The company is providing 1+1, approximately 2 lakh rupees per cycle. Means and chemotherapy more than you can say 2,50,000 rupees per cycle, 21 days. Because one cycle is provided by the company as a PEP program. The Chinese molecule tislelizumab is available. But the important thing is that we are using pembrolizumab for last more than decades. We know the results. Number not only hundreds, we have more than hundreds of patients treated by us rather than tislelizumab. I still believe pembrolizumab, paclitaxel, carboplatin, standard care as per US guideline and our experience in India.
Sir, role of radiation.
Is that sir has clearly told each and everything. And first, there is a swelling with submandibular, and that's neoadjuvant chemotherapy was given, and after that radiation. After 6 months, there is a tracheal growth. So, if at that time there is a bleeding, yes, there is a definite role of radiation to control the bleeding at that point. And after that, we should start with the immunotherapy or chemotherapy. And after 2 or 3 cycles, we should reassess. Because if the patient is in the submandibular gland and the MUO, most probably the patient would not have received the radiotherapy at the tracheal line. So after giving the radiotherapy, we must recheck the patient what is the status of the disease. At that point, we can add the radiation to the local site so that it gives the towards we can say to the ablative dose to the photos radiation.
Right.
That is my
Sir, with the therapy that you said, what are the chances he will survive? So, honest answer. Because he is a very poor patient.
So, okay, I am very clear. I never say anything which is not practical. I tell you, in last 3 decades, people realize that once I am saying something and I am writing on paper means 100%, not less than that. Pembrolizumab I have given in hundreds of patients, and by few patients, my word is few patients. Those who received 35 cycle, even after metastatic disease, they are surviving more than 5 years. They are under my follow-up. If you want, I can give you name and telephone numbers. You can talk.
Right. Sir, you are my next reference. Okay. Now, sir, I have a case who is 52 years. He was operated by Dr. Rana Patir in 2005 for a cellular-based tumor. He is presented to Manipal Hospital, your competitor in Dwarka. So he presented with a left sinonasal polyp. दिखाओगे जरा वो ब्रोंकोस्कोपी वाला जो दिखा रहे थे अभी कृष्ण कुमार यादव साहब, आप दिखा दो उसको। हाँ कृष्ण कुमार यादव दिखा दो इसको एनलार्ज हो सकता है ये
लार्ज हो सकता है सर
कर दो एनलार्ज ओके सो लेफ्ट साइनोनेजल पॉलिप राइट साइनोनेजल सॉलिड ट्यूमर on gross morphology left sinonasal polypoidal mass received single grey white soft tissue piece measuring 2 by 1.5 into 1 centimeter. Impression left sinonasal polypoidal mass, right sinonasal solid tumor, poorly differentiated malignant neoplasm. And we were waiting for the IHC report. I'm sure, sir, this is the this thing, and I'm coming to his IHC, sir. First, I would like to tell you about the CECT which was done at Mahajan. See, sir, this is an important case for me, and I want to understand the chronology of events. CECT PNS features are suggestive of a heterogeneously enhancing soft tissue mass involving the sphenoid sinus slightly to the left from the midline with associated complete opacification of sphenoid sinus and a mass extending into the left nasopharynx and nasal cavity causing significant numinal compromise of the left sided nasopharynx and nasal cavity. This mass is causing erosion and destruction of the clivus and sphenoid bone on left side with encasement of adjacent cavernous segment of the left internal carotid artery suggestive of neoplastic mass. The possible differential diagnosis could be a nasopharyngeal carcinoma, number 2 a chordoma arising from the clivus. However, histopathological correlation is needed to correlate clinically. Right. So now we are coming to his this is SDG PET scan, and the impression that I am going to read is in this recently diagnosed case of malignant neoplasm diagnosed from sinonasal polypoidal mass, FDG PET CT scan findings reveal heterogeneously enhancing FDG amid soft tissue lesion in the sphenoid sinus with extension infiltrate as described above, likely corresponding to the known primary mitotic pathology suggested histopathological correlation. So now let's come to the alright. So we have here impression tumor size from the grade 2 centimeter additional dimensions, etc. etc. Impression left sinonasal polypoidal mass. Overall immunohistochemistry favors a diagnosis of pituitary neuroendocrine tumor. This is from Dr. Mahajan. Patient was not satisfied, and I referred him again to Dr. Amish Vora, who sent his slides to Pune to Dr. J Shah, who is a disciple of Dr. Anita Borges. They worked together. They were together in Tata Memorial when Dr. Amish Vora was working with them, and report came lineage pituitary tumor, pituitary endocrine tumor. Sir, I would now like to ask from you, a patient who was operated in 2005, a cellar-based tumor, probably it was a pituitary adenoma at that time by Dr. Rana Patil, and has now come to a place now where we have a lot of erosion of the surrounding areas. How would you approach this case, sir?
First of all, whether the radiation has been given that one?
There was no radiation given. He was asked to follow up. He followed up for 2 years, and after that he never went to Dr. Rana Patil after 2005, unless he started having nasal obstruction and headache again in 2026.
So definitely, in this case, I don't think so any surgery can be done. So the only option remains is the radiation.
All right. Sir, what is the prognosis?
And in the this pituitary adenoma, usually responds to the radiation therapy well, and we will give 50 grade 25 fractions 5 days a week for 5 weeks. And mostly in these kind of tumors, the further destruction is stopped, and the overall quality of life and prognosis is good.
Right. Sir, any role of chemo or immuno?
Actually, there are two things. You mentioned about that nasopharyngeal tumors could be a nasopharynx. You mentioned about nasopharynx. The question is that if there
Sir,
is
the issue is that he had already been operated by a neurosurgeon for a cellular-based tumor. It is most likely recurrence of the same.
yes,
Let us
yes,
understand the chronology.
yes. So there is no question of a nasopharynx.
It is not a question of nasopharynx.
Okay, so we exclude that. We exclude that. Pituitary tumors is a baby of neurosurgeons or the radiation oncologist. It's not the baby of medical oncologist.
So Dr. Sharma is the right person?
Yes.
And he says no surgery, not even debulking, sir?
Possible.
You don't
Because
think
the
it's-
carotid is also involved.
Yes. So
Frontal side and sphenoid side and carotid is involved. There is
very
no
risky, very risky. So radiation oncology, sir, prognosis.
problem is good.
Great, sir. Even at this stage?
Yes.
Even with the encasing of the internal carotid artery?
Yes.
Right. Any other questions? Any other questions? Sir, wonderful interaction by you. For me personally, it has been very nostalgic to meet Dr. Sunil after so many years. He has been avoiding me, honestly. I wanted to call him last time, but sir, he just escaped. And I told Rahul, you tell Dr. Sunil that I worked with him in Ramadan. He will come this time. And Dr. Sharma, it's been a wonderful meeting with you. I would give it to my moderator to sum it up. First to Dr. Kalra sir, and then to Dr. Tulsi.
सर समरी तो ये है कि एक बार फिर मिलना पड़ेगा जो कुछ सुना है याद तो हुआ है पूरा नहीं हुआ एक बार फिर मिलना पड़ेगा once more sir it was a wonderful talk really enriching and we have so many questions left I'll keep for the next time. Thank you.
Dr. Tulsi sir.
So we learned a lot of recent advances in both in radiotherapy as well as in oncology. So I think as Dr. Sunil Gupta said that God has given him the hands to heal and he is a wonderful healer. Sir, God has given you the hands to heal
Yes.
such a dismal disease.
I'm not treating, he is treating, I'm the only messenger.
Wonderful, sir. Thank you.
Thank you.